All right, let's dive straight into this explainer. In the clinical space, time is literally tissue, so we are jumping right into a high-stakes, real-world scenario. Today, we're dissecting the intricate mechanisms and absolute critical management steps of epistaxis. We're building a 280-plus board-level understanding here. We'll map out the anatomy, and more importantly, we're going to uncover a lethal procedural trap that loves to hide behind a facade of clinical stability.
Picture this. You've got a patient presenting with acute, unremitting hemorrhage from the upper respiratory tract. Your immediate, absolute clinical directive: stratify this bleed. Are we dealing with an anterior or a posterior vascular matrix? Listen, this single anatomical distinction isn't just basic trivia. It completely, 100% dictates your management algorithm, your procedural intervention, and ultimately the patient's disposition.
Module 1. The anterior matrix. Okay, so this is overwhelmingly the most common presentation of epistaxis you're going to encounter, but it is deceptively nuanced. The anterior nasal septum is this incredible vascular nexus, specifically a highly perfused area we know as Kisselbach's plexus. Now, bleeding here is driven strictly by localized trauma, and frankly, that usually just means aggressive nose picking, or it's from environmental factors like really dry air completely desiccating the mucosa. Your management here is strictly algorithmic. Step 1, direct compression for 5 to 10 minutes. Step 2, topical vasoconstrictors like oxymetazoline. Step 3, chemical cautery using silver nitrate, assuming you can actually visualize the specific bleeding vessel. And keep this in mind, anterior nasal packing is an absolute last resort. It's strictly reserved for bleeding that flat out fails chemical cautery. Now, there's a highly specific, very frequently tested pathology right here: pyogenic granulomas. The target demographic: pregnant females. These are highly vascular, reactive hyperplasias sitting right there on the anterior septum. They can look surprisingly aggressive, almost mimicking precancerous lesions, but actually, scratch that fear, they are completely benign. Their clinical signature is simply frequent, recurrent epistaxis during pregnancy, just purely due to that intense vascularity. So, to close out this anterior matrix, let's establish our baseline disposition. An isolated anterior bleed, say a child with a bleeding nostril, or our pregnant patient with that granuloma, typically just requires localized management, like that silver nitrate cautery we talked about. Once they're stabilized, it is perfectly safe for immediate outpatient discharge. Lock that baseline in because we are about to drastically escalate the acuity.
Module 2, the posterior matrix.
Right, here is where the scenario dramatically shifts into a high-acuity arterial catastrophe. We are no longer dealing with some superficial venous oozing. Posterior epistaxis targets an entirely different demographic. We're talking older patients burdened with severe hypertension, advanced atherosclerosis, or heavy coagulopathies. This hemorrhage is strictly driven by the sphenopalatine artery, which is a deep, extremely high-pressure terminal branch of the maxillary artery. The absolute clinical signature you're looking for: massive, rapid bleeding that flows strictly down the posterior pharynx. It will completely ignore any anterior compression you attempt. Chemical cautery here: physically impossible. The absolute mandate is inserting a posterior nasal pack, like an Epistat balloon catheter, to forcefully tamponade that artery right against the bony choana. But, there's a really fascinating exception to that older patient rule, and that's the juvenile angiofibroma. If your patient is an adolescent male presenting with unremitting epistaxis, you need to immediately look for 2 absolute markers: a localized posterior mass and bony erosion on imaging. If you see those markers, the diagnostic mandate is incredibly strict. It is an angiofibroma until proven otherwise. Let's isolate these diverging presentations just to really solidify your differential. On the anterior side, you've got the pregnant female with a pyogenic granuloma. Highly vascular, sure, but superficially manageable. Contrast that directly with the adolescent male presenting with a posterior mass and bony erosion. That indicates a deep, structurally destructive arterial bleed. These are 2 completely distinct clinical entities, differentiated entirely by the anatomical origin of the hemorrhage and the specific patient demographic. Module 3, the nasal packing trap. Okay, this is arguably the most treacherous part of our explainer today. You've successfully identified a posterior bleed. You've executed the medical mandate of placing a balloon pack. You might take a breath and think the emergency is over. It's not. The mechanical management of massive posterior epistaxis introduces severe, completely masked systemic complications. We see a rapid, frightening escalation from a routine, life-saving procedural intervention straight into a life-threatening systemic cascade. At hour 0, you identify the hemorrhage. By hour 1, you insert the posterior packing. But check this out. Within 24 hours, that packing material becomes a massive nidus for bacterial inoculation. And by 48 hours, bacterial toxins are actively releasing directly into your patient's bloodstream. This builds right into our first major threat, staphylococcal toxic shock syndrome, or TSS. Nasal packing material is notoriously documented as a strong trigger for it. By leaving this foreign material inside the highly vascularized, definitely non-sterile environment of the posterior nasopharynx, you are risking the transformation of a localized bleeding issue into a devastating systemic hemodynamic crisis. We're talking aggressive hypotension and multi-organ failure. But TSS isn't even the only lethal threat here. And honestly, this is where human physiology gets wild. Inflating a balloon deep inside the posterior nasopharynx aggressively stimulates the trigeminal vagal arc. We call this the nasocardiac reflex. Think about that for a second. A simple nasal intervention can trigger a massive vagal surge that strictly drives sudden, severe bradycardia, profound hypotension, and even apnea. Because of this, the absolute clinical directive, the admission mandate, is that any patient receiving a posterior nasal pack absolutely must be admitted directly to the intensive care unit for continuous cardiac telemetry and airway monitoring. There are 0 exceptions to this rule. The master case. Testing the nuance. Let's run a final assessment blueprint to really test your deep integration of this material. Imagine a 68-year-old male presenting to you with massive, unremitting epistaxis. Blood is actively pooling in his posterior oropharynx. A dual balloon posterior nasal catheter is successfully placed down in the ER and it completely arrests the bleeding. Right now, the patient is totally stable, normalized blood pressure, 0 active bleeding. So what is the definitive next step in his management? This right here is the ultimate diagnostic trap. His perfect, calm stability is actively tempting you to downgrade his level of care. Let's break down the exactly 5 disposition options you might face here. Option A, discharging him home with prophylactic antibiotics, or option B, admitting him to a general medical floor. Both might seem entirely reasonable because, hey, he looks stable, but both are completely incorrect. They flat out fail to monitor for that lethal nasocardiac reflex or a rapid TSS onset. How about option C, removing the packing to observe? Nope, that just invites an immediate massive hemorrhage recurrence. And option E, immediate surgical arterial ligation, that's a vastly premature operative escalation since the packing currently has the bleeding stabilized. That leaves us with only one absolutely correct pathway. Option D, admit to the ICU for continuous telemetry and monitoring. It is the strict mandate to continuously monitor for the dual threats of staphylococcal TSS and reflex bradycardia. You see, even when the anatomy appears completely controlled and the bleeding has entirely stopped, mechanical success absolutely does not negate the impending systemic risks. The mere presence of that packing itself is a ticking clock for TSS, and it's a constant physical trigger for the vagal nasocardiac reflex. Clinical vigilance in the ICU is mandatory. So I'm going to leave you with this provocative thought to carry directly into your clinical practice. When you are managing an acute head and neck vascular catastrophe, are you treating just the bleeding vessel, or are you prepared for the systemic shockwave the intervention leaves behind? Because stopping the bleeding, that's only step 1. Anticipating the systemic collapse is what truly defines top-tier clinical mastery. Thank you so much for joining me for this explainer. Keep your differential broad and your monitoring strict.